Hello, this is Jeremy Leslie, and I wanted to discuss some issues that providers may be having with Diagnosis Assistant. The first issue I want to discuss is relating to display of the diagnosis on the diagnosis and problem screen. By default, the first column will be Clinical DX, which will show the ICD-10 term. However, frequently the ICD-10 term is not a clinically useful term for information exchange, and it's somewhat unwieldy. I'll give you an example. If the provider puts in the terminology lung mass in the IMO search box and adds that to the diagnosis, the clinical diagnosis will be other nonspecific abnormal finding of lung field, which, while appropriate, is not very clinically useful. There is a way to change the display settings that may make this work a little bit better. In the banner Clinical Diagnosis, if you right-click and go to Properties, you can then select a condition name and add it to the display columns, select it, move it to the desired position, which would be second, and hit OK. And now the display will show condition name, lung mass, which is the terminology the provider provided, and the ICD-10 terminology. The second issue relates to basic UI design. For example, if we are putting in a right radius fracture and it has the unspecified, so we click on this to open Diagnosis Assistant. If someone selects a fracture of radius in the clinical core column, the provider must rethink and then switch their previous selection. They cannot select a displaced fracture of the radius unless they first click on the fracture of the radius again to deselect it. This is not the typical UI of most programs that providers have experience with. Another issue providers may be having is that selections of specific terms that are clinically appropriate in the Diagnosis Assistant columns may not lead them to the terminology they were searching for. For example, if someone has a closed right displaced Barton's fracture and selects the Diagnosis Assistant from the fracture of the right radius, selects closed, and then displaced, they would not have the option to select Barton's. They would have to know that Barton is one of the options in the clinical subset category. Another problem providers may have is that when they attempt to further specify, they cannot. For example, if I put in left MCA stroke, and then attempt to specify it, the options I'm provided with do not allow me to specify it appropriately. My choices are unspecified, unspecified, or not the appropriate terminology. In case someone is wondering, the further specificity should be either thrombotic or embolic. Another example of this would be if someone put an acute kidney injury, which is a pretty common clinical term used in admission, and they go to Diagnosis Assistant, and that would map to acute kidney failure. However, they would be unable to further specify that kidney failure with this process. Another issue that may cause trouble for providers relates to ICD-10 terms that they do not have the clinical ability to further diagnose. For example, if we put in the term diabetes type 2 with retinopathy as a complication, as an internist, that would generally be some fairly specific information and likely the limit of the information that they would have. However, it's going to lead to an unspecified ICD-10 term. By clicking on the Diagnosis Assistant, you'll see multiple options. Now, if someone were to choose the diabetes type 2, they would see a scrolling list of subsets of diabetes type 2. In that subset, if you scroll down, you can get to the retinopathy section, and there are choices between mild non-proliferative, moderate non-proliferative, proliferative, severe non-proliferative, and unspecified retinopathy. Of course, most internists would have no information that would delineate which one of these options were most appropriate and have to click unspecified. Subsequently, they would then have to click with or without macular edema, again a clinical term that they have no knowledge base to make a decision on. Presumably they would select without macular edema. Now, in the end, this turns out to be the exact terminology that they started with in ICD-10 and will still be unspecified. Another example of this issue may be, for example, a right distal radius fracture. That will bring an ICD-10 term of unspecified fracture of the lower end of right radius initial encounter for closed fracture, which will be unspecified. If the provider then attempts to specify the term using Diagnosis Assistant and selects fracture of radius, they are confronted with an array of eponyms that are not widely used outside of orthopedics. Someone who is not intimately aware of these eponyms may not be able to select the correct terminology. Another issue is that many ICD-10 terms are unspecified, but yet the appropriate diagnosis to include. For example, pneumonia. In all patients without a confirmatory culture will always be pneumonia unspecified. Similarly, bronchitis without a causative organism will lead to an unspecified code. Another problem may arise where the provider lacks the knowledge of the terminology that is used in the coding set. For example, if the provider selects migraine and attempts to specify it further with Diagnosis Assistant, they would reasonably know how to select migraine with or without aura, but may not know the exact definitions of intractable or status migrainosus, and they would have to make a decision before they could adequately specify the terminology.